Start? Testing, testing, hello. Can everybody hear me okay? All right. Thank you so much for having me. I am Dr. Shadi Ireifej. I am giving this talk on behalf of Dr. Justin Ganjei, who could not be here at last minute due to a family emergency. I did talk to him last night and this morning, and his family member is doing fine, but that's why I'm stepping in for him. So I'm going to do my best to give his lecture justice with all the hard work that he's doing with minimally invasive surgery. So this is Justin here in the OR, and then here's Justin and I, sad that he couldn't be here. So a little bit about me. I graduated from Cornell University in 2006, did my one-year internship at Angel in 2007, 2 surgery internships, surgical residency at Long Island veterinary specialist. From then I moved out from New York. I went out west, worked in Las Vegas. From there, California, and then finally ended up back in Las Vegas operating a telehealth platform called Vet Triage. And we want to thank Zomedica for sponsoring this talk. We are going to show their products here. They have awesome cutting edge stuff. And please visit their booth 620 here in the exhibit hall. Again, thank you so much, Zomedica, for sponsoring this talk. Here's a brief overview. Advantages and disadvantages of minimally invasive surgery. We're going to go over laparoscopic, thoracoscopic procedures, near-infrared fluorescent imaging, and anesthesia. All these topics are kind of going to intersperse amongst each other, so they're going to overlap a lot. So when you talk about minimally invasive surgery, you think about what are the benefits, what are the advantages of it, and so decreased patient morbidity, of course, faster recovery, faster discharge from the hospital, less analgesics consumption, enhanced visualization, smaller incisions. All these things go hand in hand. We're all fairly familiar with this in contrast to open procedures, but these are all the reasons why we love minimally invasive surgery, all the patient benefits. Here's an example of enhanced visualization. You can see the ureter here, peristalsis in this patient, and just amazing detail that is hard to appreciate with open procedures. Some disadvantages, of course, longer anesthesia times, although this is debatable. There are papers that show, depending on the procedure and the skill set of the surgeon, sometimes minimally invasive be faster than open procedures. Increased costs, potentially, requiring special equipment and training, and higher dependency on advanced imaging. So there's a steep learning curve. You have to want to be really good at this to dive into it. You also have to have a client demographic that is willing to pay for this, that wants minimally invasive surgery. So it's not for everybody at every practice, but these are some of the downfalls to it. So basic principles of laparoscopy. So the abdomen is prepped as if an open ciliotomy is needed. If you have to convert, meaning you're performing a scope, and then suddenly you run into a crisis, and now you have to convert over to an open procedure, you always shave the patient, whether it's abdominal or thoracic, as if you might have to convert to an open procedure. And then there's 2 different techniques used to access the abdominal cavity. The Hassan approach or the modified Hassan approach, which is the open approach, small incision, and then placing your instruments through that stoma, or the Varus needle, which is the closed or blind approach to it as well. And the goal here, at least with the abdomen, is to insufflate it with carbon dioxide. This increases your working space, helps displace the organs, helps you visualize the organs better. And you can perform this with either multiple ports or a single port, or use natural orifice depending on what you're trying to achieve. You will need multiple specialized instruments to perform the procedure. And there's many different indications. This talk, we're going to go over a variety of different cases that we use to leverage these techniques, but there's much more. And Dr. Ganjei is really great because not only is he an excellent communicator with his clients, he's not afraid to push the limits when it comes to scoping procedures. So the first one we're going to talk about here is splenectomy. It's a common tumor diagnosed in dogs, typically older. Roughly speaking, in studies looking at laparoscopic splenectomy, the majority of cases is for neoplasia, about 90% or so, depending on what data set you're talking about. And of course, with ruptured splenic masses, we're all familiar with hemangiosarcoma, and typically, if you don't have a hemoabdomen, it may be more likely to be benign. But regardless, here are the indications for laparoscopic splenectomy. So about 90% or so are probably going to be neoplasia, about 5% refractory immune-mediated thrombocytopenia or immune-mediated hemolytic anemia, and then splenomegaly, probably about 3% of cases. And whether or not you're going to perform fully laparoscopic versus laparoscopic assisted, up to you. but we do see in the literature low complication rates, and you can move masses that are pretty sizable depending on your skill set. So here's an example of Dr. Ganjei performing the laparoscopic splenectomy. It's a nice clean dissection. This was a case specifically for refractory ITP or IMHA, so that's why you're not seeing any overt nodules on here or masses. But you can see how nice and clean this is. You're not necessarily going for margins. This is not a hemoabdomen. You can perform laparoscopic splenectomies with a mild hemoabdomen. At least Dr. Ganjei has done it. But generally speaking, hemoabdomen is contraindicated for laparoscopic intervention. But for mild hemoabdomen, you could consider it, depending on your comfort level and your skill set in the case. So here he is going through with a ligature device, completing the splenectomy. Nice and clean, straightforward procedure. And then here's that same patient here, removing the spleen from the abdominal cavity after the splenectomy is performed. Yay! And then here's the dog after surgery, as if nothing happened, right? This is the main benefit of laparoscopy, right? It's quick patient recovery. They're up and walking within hours. How many folks here, by any chance, perform laparoscopic procedures at their facility? Nice, great. How many folks would, if they had clients that wanted it, or they had the room or a potential ability to have the equipment? How many folks do want to do? Okay, a few. Okay, yeah, good. So next up is adrenal neoplasia. Uncommon, affecting about 1% of dogs, primarily affects middle-aged to older dogs. Try it and unplug. Do you mind getting the AV guy? Never mind. Hello? Okay, thank you. Yeah, there's a microphone. I have a microphone here. Oh, hello, we're back on. Okay, let's see what happens. Okay, all right. So adrenal neoplasia affecting older dogs between 9 and 11 years of age. They can be functional, non-functional, benign or malignant. So we're always worried about pheochromocytomas, but they can also be cortisol secreting. They could be secreting androgens and aldosterone or a combination. Locally aggressive neoplasms with low rate of distant metastasis, and they can be locally aggressive, especially with pheos. And we're all familiar with the difficulty with pheochromocytomas. Adrenocortical tumors can present with signs of Cushing's disease, polyuria, polydipsia, alopecia, appetite, panting, abdominal distension, and then the pheos, you can have hypertension, panting, restlessness, tachycardia. Surgical excision is treatment of choice. Associated with prolonged survivals, potential for vascular invasion and hormonal surges, increased risk of complications with surgery. Again, those of us who perform adrenalectomies are quite familiar with this. Mortality rates, wide range. Just like many of these complex diseases that are systemic, wide range of mortality rates, and we do see higher mortalities. And I find the same thing with any kind of emergency surgery, whether you're talking about a septic abdomen, a cholecystectomy. Anytime you perform procedure in an emergency setting, mortality goes up. Whereas these numbers are a bit lower when you don't have an emergency. And most often with adrenal tumors, it's a hemoabdomen that you're dealing with on an emergency basis. So laparoscopic adrenalectomy successfully performed with low conversion rates and minimal morbidity mortality. Tumor size is an important factor. Less than 5 centimeters is ideal, and you're trying to avoid it with cable invasion and larger tumor sizes. Although I will say that Dr. Ganjei has pushed the limits of that as well. Here's an example of a tumor thrombosis. He managed to palpate the phrenicoabdominal vasculature, push the thrombus back, and then complete the adrenalectomy via scoping. So it can be done even if you have cable invasion, but in general that's a contraindication for it. But just shows to you when you get to a certain level of expertise, you can really push the limits with scoping surgery to try and avoid the open approach if you can. So here's a study in 10 dogs with unilateral non-invasive pheochromocytoma. 90% did not need conversion, all discharged from the hospital. Here's another study comparing the mortality and morbidity in dogs with adrenal masses treated with laparoscopic versus open approach. The surgical time was shorter, hospitalization time shorter with the scoping group, and a low complication and conversion rate. So again, with more experience with procedures like this, you can get some pretty awesome data on it. So here's an example of a left-sided adrenal gland tumor, and this is one Dr. Ganjei really likes to cut with the scope because the cranial pole is the part that's affected, which makes it much easier for visualization of the vasculature, and also it creates a nice window here with the frentoabdominal vein where he feels comfortable scoping these from the patient. So here's a case of a chow presenting for decreased appetite. They originally ran a biochemistry panel, found elevated alkaline phosphatase. Abdominal ultrasound found a left-sided adrenal mass, so they went ahead and tested the urine for hormones there, not consistent with pheochromocytoma. Performed a CT scan, no vascular invasion, and went ahead for the laparoscopic removal. So here is the adrenal tumor here, left-sided adrenal gland tumor, and then dissection with the renal vein over the tumor. He has to gently dissect the renal vein off of the tumor in order to be able to isolate it fully. Here he's placing a polymer clip for the pedicle, and then here is showing the dissection site with removal of the adrenal gland tumor. This is the setup. He typically does a 3-port system, but in this case he had 4 ports. And so it's just a nice example of a clean surgery that normally with an open approach would give you some anxiety. He was able to perform this procedure successfully in this patient. And then here's the patient after surgery.
This is Kingston. Approximately
those of us who are familiar with open approaches are used to a patient who's recumbent and they're quite debilitated after surgery, at least for the first 24 hours, whereas with scoping they can come up and walk around pretty quick. So no complications with this patient, discharged within 24 hours after surgery, and we found a low-grade adrenal cortical adenocarcinoma, completely excised. How many folks here, when they perform an adrenalectomy or a splenectomy, if the liver looks normal, how many folks here actually biopsy the liver anyway, just in case? Okay, all right, a fair amount of you. I definitely advocate for this. Even if the liver values beforehand were normal and your imaging of the liver looks normal as well, I always advocate for a liver biopsy. Maybe if there's a financial reason not to do it, then so be it. You want to focus on the main problem. Otherwise, I'm routinely biopsying the liver, and that's whether or not you're performing an open approach or a closed approach. So this is why Doc did this, and then 2 weeks afterwards, fully recovered. Here's another example. We have a feline, and here's the adrenal gland tumor. Again, a nice isolated tumor. Doesn't look like it's invasive, and he felt comfortable scoping this. We have a cat with chronic weakness, polyuria polydipsia, hypokalemia, and hypertension, classic for primary aldosteronemia, and here are some lab values, and then we found the left-sided adrenal mass. So primary hyperaldosteronism, and because this cat was fractious, unable to be medicated, we wanted to get this cat in surgery, get him fixed up, and get him out of the hospital. And so here we are with this feline. We've got the renal vein overlying the tumor. You had to gently dissect the tumor away from the vasculature. Here you're showing the tumor here, and then just another angle of it. And then he's using a finger glove to put the tumor and remove it. It's a pretty cool case, and here's the cat after surgery. Came in for decreased appetite, and now we're already eating after a laparoscopic adrenalectomy. So speaking of liver biopsies, hemostatic agents are becoming more and more common in our field, and this is one of the awesome products that Zomedica has. The Vetigel is incredible. So instead of trying to use gel foam or trying to modify your surgical technique, if you have something like this where you have a liver biopsy, maybe you do a punch biopsy, for example, you place the Vetigel on there, and it's a hemostatic agent that will help with coagulation. It's phenomenal. And so you literally can apply this on either with an open approach or with a laparoscopic approach. So if you're interested in this, visit their booth. This stuff is great. We're always looking for better hemostasis during our surgeries. And if you're dealing with adrenalectomy, for example, which could have coagulopathies associated with it, you want to have a product like that you can use. Here's an example of Dr. Ganjei using it intra-op with a laparoscopic procedure. How many folks have used this product before? Okay, yeah, good, yeah. There you go. So there's the application of it. Boom, it's like Spider-Man. Very cool. I've gotten so frustrated with gel foam, it falls off, it doesn't adhere, and stuff like this adheres right away. So I'm a huge fan of it. Flowable hemostatic gel comprised of algae and fungi-derived biopolymers, sodium algitate, polyacetyl D-glucosamine, and water. It achieves hemostasis mechanically without the need to apply pressure. Allows the patient to form an endogenous fibrin patch, absorbable within weeks of application. So, huge fan of this stuff. Visit the booth and check it out. Okay, next up, adrenal gland anal sac adenocarcinoma. This makes up 2% of all skin tumors, 70% of all perianal malignancies. The most common site of metastasis is the medial iliac lymph nodes. Metastatic range has a pretty wide range. Size of tumor is associated with incidence of metastasis, but still large number of metastatic nodes in smaller masses. So these can be very tricky for that reason. So lymphadenectomy is a procedure you can also perform with a scope. And we know now that, in general, lymphadenectomy of metastatic lymph nodes can result in survival times of over 2 years. Lymph node recurrence or tumor recurrence, additional surgery can prolong survival times. So this has increased, and I've seen it clinically as well. It's improved the survival times, longevity of these patients. And so that's where something like this comes into play, the near-infrared fluorescent imaging and sentinel lymph node mapping. So this is a procedure used to identify lymph nodes draining a tumor, allowing for targeted biopsy or removal, and staging cancer management while minimizing unnecessary lymph node removal and or missing affected lymph nodes. So there's an argument to be made with relying on this level of diagnostic versus like computed tomography. The problem with computed tomography is you could have a normal lymph node and therefore you may not approach it surgically, whereas with near-infrared fluorescent imaging, it may light up lymph nodes that look normal on a computed tomography scan, but actually are containing malignant cells. And so here's an example of Dr. Ganjei injecting. Here's a pulmonary tumor, and he's injecting the dye, which we'll talk about in the next slide, to try and highlight where the absorption of this dye is. He has a tower that has a near-infrared fluorescent imaging 4K screen, a monitor that allows this to light up. And that's when you see the bright green color, that's the special monitor that he has in surgery. There you go. Lights it up. And so you can inject it intravenously or you can inject it around the tumor site, depending on where you're at. And then you can target your lymph nodes appropriately from there. And this is all from his special monitor that he's got that is specialized for this. So here's the dye, indocyanine green, water-soluble fluorescent contrast agent, emits a fluorescence when stimulated by near-infrared light, hepatically metabolized, excreted in bile, protein-bound, reaches peak fluorescence at 140 nanometers. How many folks here use this technique in surgery? Okay, a few of you. Yeah. This stuff is really cool. So here's an example of a dog with an anal gland adenocarcinoma, and he's trying to light up the lymph nodes here, the medial iliac lymph nodes, intra-abdominally, and so you can see here it's lighting up. And a lymph node like this may not show up on CT scan, but yet intra-op you can identify it. And this is just to show you, here's the visible light spectrum, and then towards the end is where we're working with near infrared, 840 nanometers. So this is that same patient, medial iliac lymphadenectomy. It's lighting up, and this is the dissection site. It's gone now. So this is a pretty gnarly case. You have a dog here with a digital melanoma and an ulcerated large popliteal lymph node. This owner did not want to perform an osteotomy, and so they wanted to, at all costs, avoid that, but still fix the patient. So Dr. Ganjei went over all the details with them and tried his best to remove all the diseased tissue here, and so this case ended up doing very well after surgery, but something like this is fairly extreme, where you have a patient that has multiple lymph nodes affected for a malignancy, requires careful client communication, talking about the pros and cons of doing this. Dr. Ganjei doesn't perform these procedures without further discussion with the client. So this is a really extreme case, but if you're not afraid to push the boundaries and the client understands, then sure, you can do a popliteal lymph node excision and then remove the intra-abdominal lymph nodes that are affected by the cancer. So another indication is laparoscopic nephrectomy. Cancer, hydronephrosis, here's an example. And so here he is again performing a laparoscopic nephrectomy. Gentle dissection. The renal vasculature is adhered to the tumor, and so you have to gently isolate the vasculature. And he's going to use this hemo clip. It's a hemo lock that is it's a polymer clip. It's radiolucent. It's inert. It doesn't interfere with CT or MRI. And so he'll use this for ligation. He'll place two, and then a ligature in between to sever the vasculature. So pretty suave, pretty nice. Look at that. He'll use these instead of ligature when he feels that the vascular supply is too large for ligature. He feels more comfortable using the clips, the hemolocks. So he's ligating the renal vein, and then here we've got clips on there, and then he'll transect the vasculature, and then here you have the diseased kidney with the ureter ready for extraction. And of course, many other procedures, pancreectomy, liver lobectomy, cholecystectomy, all these things, depending on your skill set and what you have available to you and your client base, you can perform these procedures with a scope. Here's another wild case. So he had Ganjei with an intrapelvic sarcoma. So this patient came into the emergency hospital with stranguria and tenesmus. Basically, by the time he showed up to the ER, we have a full urinary obstruction. So you have this intrapelvic mass taking up the space here in the pelvic canal. And this is a urinary catheter here, showing you the location of this. There's the urinary catheter right there. So he spoke with the owners. This is obviously a novel approach with a scope, but they decided to go for it. They did not want to perform anything invasive like a pelvic osteotomy, and so we're trying now to excise this. So here is the tumor in the intrapelvic canal, and Dr. Ganjei is dissecting the tumor, trying to isolate it further, right? And so we can see here, here, this is after tumor excision, fairly about 7 centimeters or so, and you can see now the dissection site afterwards. And what he had done here is he had here's the tumor here. He had one of his assistants perform a rectal exam to help push the tumor forward. Boop, there you go. They pushed rectally, tumor popped out, and then he's there giving his assistant a high five, and there they are saying hi. So here's the patient, of course. I mean, again, you would expect, with an open approach, this would be quite invasive. With a scoping, some bruising, some swelling, but not too bad considering. And this came back as a grade 1 or grade 2 myxosarcoma. Dr. Ganjei recommended following up with chemotherapy, radiation therapy, and then reevaluation with CT in about 6 months. They did not do that. The dog came back 7 months post-op, recurrence of signs, even bigger tumor now. They repeated the procedure, which went very well, and then they followed up with chemo radiation after that. So sometimes you learn the hard way, follow the doctor's advice. So thoracoscopy, next up. How many folks perform chest scoping here? Okay, a few of you. Yeah, so not as common, does require a lot more. There's a lot more involved with this. Minimally invasive procedure allowing for diagnostic and therapeutic video-assisted thoracic surgery procedures of the thoracic cavity, first performed in 1910. Does not require capnoperineum, although you can if you need a little bit more exposure. in most cases, as establishment of pneumothorax allows for an adequate working space. It relies heavily on access to high-quality equipment and advanced imaging. So we're going to go through some examples here. Here's just a sampling of what you can perform with the scope. So Dr. Ganjei sent me this morning, I think he said 8 centimeter cranial mediastinal mass. So here's on CT scan, and then here they are in surgery, trying to remove this very large mediastinal mass from this dog. And again, this is one of those cases where normally a tumor this big would be contraindicated. But when you talk to the clients and they insist on something that's not as invasive, and they understand that you're pushing the boundaries here with this type of procedure, and they're willing to go for it, then you can go for it. And Dr. Ganjei's expertise with minimally invasive surgery is profound. He's very comfortable with this kind of thing. So he's comfortable pushing the limits as long as you speak to the clients adequately and go over pros and cons. But normally, this would be a bit too large for the majority of surgeons to perform with a scope. You can see how massive this thing is. Now typically, if you're performing a sternotomy on a dog, they would be fairly debilitated for a day or two at least. They're older dogs, they have comorbidities, they're going to be on a constant rate infusion of analgesia, right? So they're going to be out for the count. A procedure like this, you've got a dog 2 hours post-op, 2 hours after surgery, walking around. 2 hours.
You like that smell?
Smells like pee.
Let's go pee-pee.
And there's a chest tube place as well. There we go. Just phenomenal. Phenomenal. So steep learning curve, a lot of equipment involved, but if you want to dive into this world, you can get some pretty remarkable results. I'm used to seeing dogs debilitated for a bit of time, and so that's why you would choose thoracoscopy over open approaches. Here's your open approach, a lateral thoracotomy, intercostal thoracotomy, and then here's the ports, the incisions that you have with a patient that's undergone scoping. So a dramatic difference. So significantly less morbidity than the traditional open approach, reduced hospitalization time and cost, faster recovery, improved visualization, all the same benefits that you'd have with abdominal procedures. So you're going to prep the thorax as you would for an abdomen in case you had to convert. Access to the thoracic cavity can be attained via 2 methods, intercostal or transdiaphragmatic or sub-xiphoid approach. You don't usually need insufflation, although you can if you need to have a bit more visualization. And you're going to use multiple ports, but you can use a single port. One lung ventilation or CO2 insufflation is helpful to increase the working space. We're going to go over the anesthetic considerations with the scoping, because this is where it gets a bit more involved if you're going to dive into this world. One lung ventilation has effects in the patient, of course, both cardiovascular and respiratory, no surprise there. But there are some pretty suave techniques you can use for selectively ventilating either the right or left lungs to allow for better exposure of the specific area of the thoracic cavity. You can either have intubation of either side or main step bronchial blockage. I'm going to show you some of these techniques. Bronchial blockers, double lumen endotracheal tubes, endobronchial intubation. These require the use of a scope or fluoro to place them. And so here's an example where a device can be either in the endotracheal tube, like here, or it can be outside the endotracheal tube, and you're selectively choosing to aerate one side and not the other. And so here's another example. This is the endo blocker here. So it has these small tubings with the balloons, and you can selectively choose which side of the lungs you want to inflate and which ones you don't. Here's another example as well, double lumen tubes. So you've got the tracheal cuff, you've got the bronchial cuff for the right side and the left side. You've got the tracheal cuff and the bronchial cuff. So you need to do this under scoping because the anatomy is different on both sides, and you need to make sure proper placement is, of course, key with these anesthesias. So this is an added challenge with thoracoscopic procedures, but again, if you're going to dive into it, one lung ventilation is probably going to be mandatory for you for improving exposure and in the room in which you operate, recommended for certain procedures like lung surgery as well as vascular ring. However, of course, there's complications, especially perfusion mismatch, and hypoxemia, hypercapnia, pulmonary hyperinflation, induced edema, cardiac arrhythmia, decreased venous return. Of course, this is the alter the anatomy. This way, you're going to have effects to it. But here's what you're looking at with a scope, so you can visualize proper placement. There you go. So then the approaches. Transdiaphragmatic subxiphoid approach allows visualization of both hemithoraces, exploration of the ventral thorax, pericardium, cranial mediastinum. Dr. Ganjei, usually from what I've seen, prefers this approach. And there's the intercostal approach, which has limited to exploration of only one hemithorax, provides better visualization for surgical intervention. Patients are shaved and aseptically prepped to allow for median sternotomy or a lateral thoracotomy if you get in trouble. So he'll shave the entire thorax, but he's aiming for just the scoping procedure. And so here's an example of the transdiaphragmatic approach. You're not entering the diaphragm; it's literally just subcutaneous tissue, fascia, and muscle that you're entering here with this port. So the patient is in thoracic recumbency, 3-port system. One is the subxiphoid, right there, and then you've got 2 intercostal ports, left hemithorax, right hemithorax, between the 3rd to 10th intercostal space, depending on the procedure. And he likes it as ventral and as caudal as possible to maximize mobility and improve visualization. And then you want to watch out for intercostal arteries. So here's the placement of the intercostal ports. Here's an example of him approaching the subxiphoid, placed just to the right or left of the xiphoid process, directed cranially at a 30-degree angle from the xiphoid, and avoid placing the cannula too perpendicularly. You want it at an angle. So here's an example of ports getting ready for the diaphragmatic approach for the thoracoscopy procedure. And here's his setup: the tower and the patient. And then for intercostal approach, lateral recumbency, 3 ports are placed at the desired intercostal spaces for the procedure. You can have a single intercostal space. 3 ports are placed in the ventral aspect of a single space. So depending on what you're comfortable with and what you're trying to achieve, either 3 separate ports or with 3 separate incisions, or all 3 ports in one incision. And this is for open thoracotomies, but it's always a nice reminder of what anatomic structures you're trying to target and what intercostal spaces you want to plan for with surgery. And then just the comparison of the two approaches for thoracoscopic procedures. And the patient there, you can see, I mean, again, we're used to seeing large incisions with lots of bruising and swelling. With scoping procedures, you've got some small incisions, chest tube placed, all good to go from there. So mediastinal mass resection, like you saw in that other case, thymoma, ectopic thyroid carcinoma, thymic carcinoma, low mortality, morbidity. Here's an example of a mediastinal mass with some sort of adhesion there to the ventral portion of the thoracic cavity, and typically associated with an excellent long-term prognosis. Another example here with a husky. They found, incidentally, a craniomediastinal mass on radiographs, 5 centimeters size, non-invasive. And so here's Dr. Ganjei trying to dissect out the mass. Here, trying to do a gentle dissection, and slowly but surely trying to isolate the mass. This is lung here, and there we go. And then this, so he's got the mass isolated, and then after he's finished, he's using a guide wire to place the thoracostomy tube, the chest tube. I think this is the cotton tip applicator, the peanut instrument there, and then he's using the ligature to help with blunt dissection and then cauterizing the attachments. And this is the dog. I think he said this was like a week post-op, comfortable, happy at home. And so, some of the problems that we have, especially with, we all know huskies, they're loud, they're high anxiety, and so when you have an ICU barking and yelling, you want the patient out. And so a very nice approach, and again, this is another shout out to Zomedica, is telediagnostic. So I'm currently in the telehealth space, and I'm a huge fan of anything that's remote. And so with patients that are critical, especially if you're dealing with chest surgery or critical abdominal surgery, you want to have a way, if you can, to monitor the patients from afar. If you're trying to get the patient out of the ICU into a step-down ward, but you still want to monitor them carefully, telediagnostics like this device, the Vet Guardian, are phenomenal for that. This is able to, without any wires, this is able to remotely monitor the patient's vital signs, temperature, heart rate, respiratory rate. It alerts you, it saves everything to the cloud, and it uses thermography as well to have actual visualization of the patient on video. So it's a constant monitoring that goes to an app, on your device, you can have multiple patients. So this is just one patient here, but you can have multiple patients that are being monitored by the VetGuardian device. And this is great for those patients that are still needing monitoring, but you want to get them out of the ICU, or perhaps you need more room and you're trying to use something that doesn't take up that much room, or you're understaffed. You don't want to have your staff continuously monitoring the patient manually. If you have something that can monitor them from afar, something like this, the VetGuardian is excellent for that. And so I encourage you, again, go to their booth, learn about this stuff. We are seeing the beginnings of telediagnostics in the veterinary space. We are nowhere near where we're going to be in the future with this stuff, and we already are doing it with glucose monitoring, for example, for diabetics. So I'm a huge fan of these types of diagnostics. Pericardial window, another example of how you can use scoping for these cases. Resection of a small 3 to 4 centimeter diameter area of pericardium over the apex of the heart. You can relieve clinical signs associated with pericardial effusion, whether it be idiopathic or neoplastic. Indications of pericardial effusion, usually idiopathic or secondary to cancer. I will, of course, make the argument that without intervention surgically and biopsying and culturing, I'm not sure you can call it idiopathic. We blame a lot of things on idiopathic disease, but without an actual workup with it. So keep that in mind. I also find that a lot of times emergency doctors want to quickly give these patients a death sentence when in reality, if you do have true idiopathic pericardial effusion, they may do fairly well with a subtotal pericardectomy or a pericardial window. So I do think that we have to realign our emergency department on how to think of these cases. So the important thing that Dr. Ganjei is showing here is retraction of the pericardial sac away from the heart. You can see the pericardial effusion within the pericardial space, and he's carefully pulling upwards so that when you ligature the tissue, you're not contacting the heart. And then here's the size of the pericardial tissue removed for a pericardial window. For a subtotal pericardectomy, we're removing a larger portion of pericardium. You're using this for, again, idiopathic pericardial effusion, constrictive pericarditis, and chylothorax. And here's an example of tissue being removed. And so here is Dr. Ganjei, again, removing tissue. If the patient is small enough, or the tissue is not as thick or not as vascular, he'll use scissors first to make his window, and then continue on with a ligature device, or he'll perform the entire procedure with scissors depending on his comfort level with that patient. So here's all the different diagnoses that are possible when you're dealing with pericardial effusion and all the different outcomes. So another indication, of course, is auricular tumors, usually hemangiosarcoma. And here you have an example of the right auricle along with a mass. This is here is the heart still not without a pericardiectomy yet. This is in pericardial effusion or tamponade, and then he's resecting it to get exposure to the auricular mass and then excising. Now the thing is here with what Dr. Ganjei does with these procedures is he'll perform his subtotal pericardectomy, of course, at the apex of the heart, but he's going to orient it a bit more cranially. That way, through the same pericardial window or subtotal pericardectomy, he can access the right auricle. So he doesn't have to rotate his position at all when he's performing these. If he knows he's aiming for an auricular mass, subtotal pericardectomy, a bit more cranial than normal, and that gives you access to the right auricle to remove the mass or perform the auriculectomy. So hemangiosarcoma primarily affects the right atrium, but can affect ventricles and other chambers associated with intracardial hemorrhage and tamponade. And here's an ultrasound. You've got the right atrium, right atrial appendage or auricle. And you can see the mass here, and then more clearly in this ultrasound image, you've got pericardial effusion, nicely outlining the mass. So of course the prognosis depends on what the cause is, but we often see hemangiosarcoma, and here are some stats for you for those who are going to achieve this, or if you want to share this with clients. And for the right client, this might be something to consider. So patient selection, of course, is very important. And that's why I kept stressing, even with extreme cases, Dr. Ganjei is upfront with clients about pros and cons, especially with cases that are a bit less conventional. Tumor location is helpful in determining a good candidate for minimally invasive surgery versus open versus non-surgical. Tumors located at the distal aspect of the auricular appendage are good candidates for a thoracoscopic approach. Tumors located more at the base or the atrial wall are not good candidates, and imaging can be helpful in determining who's a good patient and who's not for this. So here's an example of a case here: acute collapse, pericardial effusion, tamponade, ultrasound found the mass, no evidence of pulmonary metastatic disease. And so this patient had a history of muscular hemangiosarcoma, and they went ahead and performed the procedure, discharged 24 hours after surgery. Pretty amazing. Cardiac hemangiosarcoma, completely excised, and by 2 weeks post-op was doing pretty good.
Come on. Come on.
Chest tube in place, hanging out.
No, that's not your food.
Lung lobectomy. Here you've got a pulmonary mass. You can perform these as an assisted or total thoracoscopic approach. Small to medium-sized tumors are ideal candidates, and you can also remove metastatic disease, which will show you an example of that as well. One lung ventilation, of course, is going to be helpful. And then you have a study here looking at dogs with primary lung tumors. Median survival time 168 days, but a wide range because it depends on what kind of tumor you're talking about. The majority of these are going to be adenocarcinoma, usually alveolar or bronchial in origin. So here's a crazy case again, another Dr. Ganjei special, a Doberman with a history of osteosarcoma, so it had an amputation performed, followed by chemotherapy, and now we've got a pulmonary mass as well as other nodules. These patients wanted to perform the mass removal of the pulmonary nodule, not because of metastatic disease, but because the patient was suffering from hypertrophic osteopathy. He was fairly lame, and he's already 3-legged. And so they wanted to remove the mass in the hope that the HO would resolve. That was the goal here. And Dr. Ganjei, of course, stressed to them that that's not a guaranteed thing that's going to happen. That's not a legitimate way of tackling this. But if you want to do it, we can give it a shot. And so Dr. Ganjei went ahead and explored the thoracic cavity, and here he is trying to dissect out and remove that one large mass. Here's the aorta, and using a ligature device, you can, again, he's going to ignore the smaller masses. He's going for the large one. We are presuming that the large mass in this case is the cause of the hypertrophic osteopathy. We don't know, right? We don't know. This is just this is the right owner for the right situation, and they're willing to give it a shot. And so here we are trying to remove the metastatic mass. And you can see how one lung ventilation really helps, right? Can you imagine that the lungs keep inflating and affecting your surgical site? You would never get through the surgery. So it's for cases like this especially, it's pretty much mandatory to have one lung ventilation for these cases. There's the cut surface. And the patient did great. His hypertrophic osteopathy actually resolved after removal of this tumor. So obviously a very unique out there case, but it just shows you client communication is important. And if you're comfortable with procedures like this, then you can get fairly creative with how you approach these cases. And that's where we're at. I want to thank Dr. Ganjei for supplying these slides. This is his talk. Hopefully I did him some justice. If you guys have any questions that I can't answer or specific to these slides, feel free to reach out to him. That's his contact information there. And then any questions for me, that's my contact information. I'm happy to take on any questions or comments you have. Thank you for attending. Okay, enjoy the conference. Thanks, everybody. Thank you.
I was not expecting this to be here. How you been?